Thank you, Dr. Sandeep, and thank you, Dr. Rajendran, for the good presentation. Now we go on to the second session, that is case presentation. First case title X-Files, and it is presented by Dr. Nitish Primahar, DNB resident, Department of Medicine and Medical Trust Hospital, and the moderator for this is Dr. Deepu George. I welcome Dr. Deepu George to conduct the session.
Thank you, API Kochi. It's always nice to be back on the floor of API. In fact, I apologize if I sound a little sick. I am a little sick from afternoon, but I took a leave in the afternoon just to be back like a homecoming. You know, API is almost like our own Tarwad. So I apologize for the sound, and I invite Dr. Nitish to present the first case. We'll keep it extremely short. I assure you that it's hardly going to take 7 minutes from my side, so that Eben has at least 10 minutes and we'll wind up by 9:15. Over to you, Nitish.
A very good evening to everyone gathered here. I am Dr. Nitish Premha. I'm a DNB resident from Department of General Medicine in Medical Trust Hospital, Kochi. I'm here presenting a very short case on X-Files. So we had a 67-year-old diabetic male. He presented to us with complaints of progressively worsening hand trauma for the past 4 years. It was predominantly in his right hand, and it's gradually progressed over the past 4 years. Initially, he had trauma only at rest, but over the past 4 years, it gradually progressed to involve during activities as well, and thus restricting his day-to-day activities. He also had complaints of increased urinary frequency over the past 3 years. It was associated with urge incontinence, but he was able to feel his bladder and he was able to empty his bladder as well. And he had difficulty in forming new memories for the past 1 year. It was noticed by his wife. It was manifesting mainly as repeated questioning, and he was usually forgetting his payments. There was no complaints of any faults, and he never had any gait initiation issues, and there was no any weakness, and no other abnormal movements were noted. He was a non-diabetic on irregular medications. His family history revealed that he had 4 siblings, 3 of them were sisters and a brother. His brother also had similar complaints from the 6th decade of life, and one of his sisters had infertility. Going on to physical examination, he was conscious, oriented to time, place, and person. His registration, attention, and calculation and language were normal. His recall is affected, and there was a mild cognitive impairment of MMSE 77 out of 30, and physical examination revealed a high arch palate. He had resting and intentional high-frequency tremor in his right hand, and there was postural tremor in both hands. His finger-nose-finger and finger-finger tests were impaired on right side, and tandem walking was severely impaired. He has reduced vibration sense in both ankles, and his deep tendon reflex, angle reflex was hypoactive. There was no elicitable motor weakness, no cogwheeling, no bradykinesia or rigidity, and no postural hypotension was noted. Going on to lab parameters, his HbA1c was 10.3, his complete blood counts, renal function, and liver function were within normal limits, his electrolytes was normal, and TSH was normal. So at this juncture, we had a patient who is around 67 years old who presented to us with complaints of tremor and cognitive dysfunction. On physical examination, he had ataxia. At this age, the probable differentials could be an idiopathic Parkinson's. However, the lack of bradykinesia and the early cognitive impairment makes it unlikely. The other differentials could be an atypical Parkinson, such as progressive supranuclear palsy. But the lack of any falls and completely normal gaze makes it unlikely. So what it could be? The answer laid in the family history. He had 4 siblings, 1 brother and 3 sisters. His brother had similar complaints, however, his sisters were spared. So the XY was more affected than XX. So we went ahead with an MRI. An MRI revealed a T2 flare hyperintensity in the middle cerebellar peduncle, a classical sign called MCP sign. So a 67-year-old diabetic male presented with complaints of progressive tremor, urinary incontinence, and cognitive dysfunction over the past 4 years, and family history of similar tremor, ataxia in a male sibling. On examination, he had resting, intentional, and postural tremors, along with dysmetria and gait ataxia. His functional diagnosis was a tremor ataxia, an MRI revealing an MCP sign. The etiology was Fragile X-associated tremor ataxia syndrome. An familial mental retardation 1 gene testing was suggested. However, the family declined. FX TAS, Fragile X-associated tremor ataxia syndrome, is an inherited neurodegenerative disorder predominantly affecting men. It is due to a CGG repeat expansion in the pre-mutation range of 55 to 200 in the non-coding region of FMR1 gene. If the repeat standard repeat extend beyond 200, you get a classical Fragile X syndrome occurring in young children. The FMRP protein is produced in near or normal levels, but however, the FMR1 mRNA transcripts are toxic to the brain, leading to the manifestations. The clinical phenotype, the age is usually around 50 to 70 years. The patients usually present with progressive cerebellar ataxia, action tremor, or a Parkinson features with cognitive decline, autonomic neuropathy, and peripheral neuropathy. Our patient had everything. And they also present with significant memory and frontal lobe executive dysfunction. Loss of distal extremity reflexes and vibration sense are also described. And axonal sensorimotor polyneuropathy has also been described. The autonomic dysfunction involves urge incontinence and a bowel incontinence. Recurrent falls may occur. After the initial motor sign, which is usually the tremor, the median delay of onset of ataxia will be 2 years. The onset of falls will be 6 years. And dependence on walking aid will be 15 years. And inability to do most of the day-to-day activities will be 16 years. And death usually occurs by 21 years. The life expectancy ranges from 5 to 25 years. The death occurs due to congestive cardiac failure, pneumonia, or a cardiac arrest, or a progression of neurological disease. At end stage, the affected persons will be usually bedridden, dysphagic, dysarthric, and without any bladder or bowel control. The female are usually spared. They may develop a premature ovarian failure. One of our patient's sisters had an infertility issue. They do not develop any symptoms like a tremor or ataxia. They have a higher incidence of migraine, chronic muscle pain, and thyroid dysfunction, the reason of which is unknown. These are the common symptoms described in literature. The most common symptoms are dysmetria, which is a cerebellar symptom, and there may be an intentional tremor or a resting tremor, and Parkinson features have also been described. They also have peripheral neuropathy and autonomic symptoms like urinary incontinence, fecal incontinence, and impotence. The neuroimaging usually reveals an atrophy of and white matter changes in the middle cerebellar peduncle, atrophy of cerebral cortex, cerebellar cortex, corpus callosum, and pons. Cerebellar and cerebral white matter has increased T2 and decreased T1 signal intensity, and middle cerebellar peduncle usually has an increased T2 signal intensity called MCP sign. The diagnostic category can be definite, probable, or possible. Definite includes one major radiological criterion and a major clinical symptom. The major includes an MRI white matter lesions in MCP or a brainstem, and the major clinical criteria includes intention tremor or a gait ataxia. The minor symptoms include a Parkinson's features, moderate or severe short-term memory deficiency, minor executive function deficit. Our patient satisfied the definite clinical criteria of one major radiological sign, which is the MCP sign, and two major clinical symptoms such as intentional tremor as well as gait ataxia. FMR1 genetic test, it usually assesses the trinucleotide repeat codon number of mutations. There are two techniques available, which is Southern blot assay and PCR assay. The Southern blot usually costs around 10 to 12,000 and PCR assay costs around 7 to 9,000. Management, there is no specific management for this disease. Usually rule out the reversible cause of dementia like hypothyroidism, B12 deficiency, and only symptomatic measures are available. Conclusion, it is important to consider FX TAS in the differential diagnosis of adults presenting with movement disorders. Clinicians who are unaware of the career status of the patients may misdiagnose FX TAS, and it is important to perform a thorough family history and consider genetic testing. Thank you.
Shall I just invite Dr. Ebin to do the second case, and then we'll have a discussion so that we'll finish both the cases. Then we'll discuss this case. Ebin, please.
Good evening. The second case, thank you API for giving me the opportunity to present. So Dr. Nixie will be presenting my case. So the case is titled The Mouse That Rode. the story of the tiny yet mighty. So this case was initially admitted under the Department of Neurology. We took over. Anyways, we'll see the sequence. Dr. Nixie, please kindly start.
Good evening, everybody. I am Dr. Nixie. Here today I am presenting the story of a mouse, tiny yet mighty. 51-year-old male who is a driver by occupation with no known comorbidities, non-smoker, non-alcoholic, was apparently normal 40 days ago. Then his wife noticed a dragging of legs while walking. Due to compulsion from his wife, he consulted Taluk Hospital, Fort Kochi. Routine investigations were sent. CBC, RFT and sodium was normal with a potassium of 1.9. He did not consult back the doctor with reports. Instead, he searched internet and started self-treatment by consuming fruits for hypokalemia for about 1 month. His weakness was progressively worsening, that he fell down from bike as he could not balance his bike. Hence, he was admitted in nearby local hospital with bilateral lower limb weakness, bradycardia, and a hypokalemia with a potassium of 1.7. He was started on IV potassium correction and was then referred for expert opinion. He got admitted in ICU of Medical Trust Hospital under Neuromedicine Department. On clinical examination, he was conscious, oriented, febrile. Pulse rate was 41 per minute. BP was 120/70 millimeters of mercury. Respiratory rate was 18 per minute and saturation was 98% in room air. He was moderately built and nourished. He had no pallor, no icterus, no clubbing, no cyanosis, no lymphadenopathy or no pedal edema. Central nervous examination showed a normal higher mental function. Normal cranial nerve examination and motor system examination showed muscle wasting of proximal muscles of bilateral lower limb with weakness predominantly over proximal muscles of lower limb. Deep tendon reflexes were normal. Sensory system examination was normal. CVS RS and abdomen was normal. Investigation. Arterial blood gas analysis showed metabolic alkalosis. ECG showed sinus bradycardia and complete hemogram showed anemia with an HB of 10.6. Renal function test was normal. Liver function test showed hypoalbuminemia with an albumin of 2.4. PT, INR, TSH and HbA1c was normal. All electrolytes were normal with a potassium of 2.2. Even though we were continuing correction of potassium, it was refractory to correction.
Receiving IV potassium almost every day. This was before we started seeing the patient. And the patient was already also getting opinions from the Department of Nephrology, Rheumatology. They were all involved in the management. I think we came a little later, after 5 days or so.
For further evaluating the weakness, MRI brain and MRI LS pain was taken, which was normal. NCV was also normal. Tumor markers were sent as he had wasting and weight loss. It was negative. ANA profile showed a Rho52 antibody positivity and Schimmer's test was positive and complements was normal. 8 a.m.
Most of these investigations were already ordered. Okay, so the initial part, this was under the Department of Neurology, so they had asked for an MRI brain, MRI LS spine, NCV, even ANA profile, because they couldn't get an answer. They had involved the rheumatologist. He asked for an ANA profile, and this was the ANA profile report with a normal C3, C4.
8 a.m. cortisol was 63. Even the 8 a.m. cortisol was high, initially we thought it was due to acute stress state. On hypokalemia workup, he had no history of low food intake or loose stools or drug intake. Urine potassium was around 32.2. Transtubular potassium gradient was 14 with normal BP and ABG showing metabolic alkalosis and urine chloride about 67. The possible diagnosis considered were drug intake of loop diuretics, thiazide diuretics, Bartter syndrome or Gitelman syndrome. Patient had no history of any intake of diuretics and hence possibilities considered was Bartter syndrome and Gitelman syndrome. Let's see about Barters and Gitelman. In case of Barters, there are 5 types. Mostly they present antenatally or during neonatal period. Only type 3 variant can present in early adulthood. They can also have hypercalciuria and normomagnesemia. In case of Gitelman syndrome, it has a later age presentation with neuromuscular symptoms like fatigue, weakness, cramps, tetany, and carpopedal spasm with hypomagnesemia and hypocalciuria. Here, keeping all the investigations and all the possibilities, we thought a probable diagnosis of acute Gittelman secondary to primary Sjogren syndrome. Hence, a lip biopsy was planned and also
So this was where we were stuck. So after the initial flowchart, this according to the Harrison's flowchart, we reached a diagnosis of a probable Gittelman's, but he was too old to present with the Gittelman's. So there are few case reports of Sjogren's presenting as a secondary acquired Gittelman syndrome. So that was the diagnosis because his ANA profile showed an RO52. Also, we had done an opthal evaluation which showed presence of dry eye. So everything was in favor of a Sjogren's with a probable acquired Gittelman syndrome, and this is what we reached as the initial diagnosis based on the flowchart. So we were planning on a lip biopsy for a histopathological diagnosis when the entire scenario changed.
he was shifted from ICU to room when his potassium was around 3.2, and oral correction for potassium also continued. While in room, he complained of right lower limb pain, and on examination he had calf tenderness. Hence, a USG Doppler was taken and which showed right lower limb DVT. He was started on anticoagulation with low molecular weight heparin for deep vein thrombosis, but he developed hemorrhoidal bleeding. Hence, anticoagulation was temporarily withheld. Due to from the bystander side, they requested for a CECT abdomen as they were very concerned since he had a hemorrhoidal bleed. Hence, a CECT abdomen was taken, which showed no significant abdominal pathology with acute saddle pulmonary thromboembolism extending to almost all lobes of lungs and a heterogeneously enhancing mass lesion in the medial basal segment of right lower lobe, probably breaking down consolidation or aerated lung within pulmonary infarct. In view of pulmonary embolism, respiratory distress, and recurrent fever spike, patient was then transferred from neuromedicine to medicine. Chest X-ray had bilateral infiltrates, hence he was managed empirically with piperacillin tazobactam and restarted on therapeutic anticoagulation for pulmonary embolism. Pulmonology consultation was sought and a bronchoscopy was done, which was normal, and BAL culture and sensitivity yielded Enterococcus and Klebsiella species. According to sensitivity, antibiotics were hiked to meropenem and teicoplanin. Now we started reconsidering the diagnosis, considering the probabilities, that is proximal weakness of lower limbs, refractory hypokalemia, saddle pulmonary embolism with a raised 8 AM cortisol, and CECT showing a heterogeneously enhancing mass in the right lower lobe of lung.
This is where we had a second thought. Any ideas, any suggestions? So after this, shall we proceed?
Here, considering all this, we thought it is probably due to a paraneoplastic Cushing syndrome, and then we proceeded with further workup. Dexamethasone overnight test was around 63. Low dose dexa test was positive with a high cortisol, and ACTH was raised, which was around 268, and high dose DEXA challenge test was negative, and MRI brain was normal, confirming ectopic Cushing syndrome. He was getting better in ICU, but he again developed recurrence of fever spike and worsening of chest X-ray with a worsening of FiO2 PaO2 fraction with severe ARDS. Hence, he was then intubated and a CECT thorax was taken. His COVID antigen and RT-PCR were negative. However, COVID IgG antibody was positive, and CECT thorax showed extensive ground glass opacities with small depending consolidation noted diffusely involving bilateral lung parenchyma, probably due to viral ARDS, and also a heterogeneously enhancing irregular nodular lesion noted in the medial basal segment of right lower lobe, approximately 23 cross 27 cross 28 millimeter, likely neoplastic etiology. And we considered, since CCT gave the picture of viral ARDS and COVID IgG antibody, we considered it to be a possibility of COVID pneumonia and PCP pneumonia, and he was then managed with remdesivir, cotrimoxazole along with meropenem and teicoplanin, and also potassium correction was continued. He improved, hence he was tapered and extubated and maintained on oxygen support. For next 2 days, he was better and his saturation was normal on room air. Next day, he again developed sudden onset breathing difficulty and chest pain, and chest X-ray showed right-sided pneumothorax. And he was then managed with an ICD. While on ICD, a CT-guided biopsy was taken, and histopathology showed small round cell neoplasm arranged in the form of cell nest and rosettes, and stroma has collagen and congested blood vessels, probably suggestive of typical bronchial carcinoid. His serum chromogranin A was also high, which was around 209. And for confirming the diagnosis, IHC was sent and it showed positivity for synaptophysin and chromogranin, confirming a typical carcinoid with low Ki67, confirming low-grade neuroendocrine tumor. And we reached the final diagnosis.
This was the final diagnosis. We never thought he would actually come out of all this. After making a diagnosis of Cushing's, we started him on ketoconazole. Then he developed a viral pneumonia. Then he developed a spontaneous pneumothorax. Finally, somehow he pulled through. He's still alive, doing well. So the last part, still not clear, the acquired Gentleman secondary to primary Jogren syndrome. We didn't do a lip biopsy because we were so carried away with the other things. He improved. We started him on ketoconazole, and his cortisol levels gradually came down. We advised him surgery because he had financial constraints. We advised him to go to Kottayam Medical College also, but as I think he's still not done the surgery still.
He was discharged with syrup KCl, ketoconazole, pandoside, and rivaroxaban, and a PET was taken to look for any other presence of any other tumors, and a PET showed only 16 cross 18 cross 23 mm lesion over the right lung lower lobe with no distant metastasis. Moving to the discussion part, ectopic Cushing syndrome was first described by Brown in 1928. It constitutes about 5 to 10% of all cases, predominantly caused by occult carcinoid tumors, most frequently in lungs, also in thymus and pancreas. It is also seen commonly in advanced small cell carcinoma of lungs, rarely seen associated with medullary thyroid carcinoma or pheochromocytoma. Clinical features: presence as proximal muscle weakness, severe hypokalemic metabolic alkalosis, hyperpigmentation, edema, hypertension, and glucose intolerance. Early diagnosis and localization of source is crucial. Medical management includes ketoconazole 200 mg thrice a day, maximum up to 1200 mg can be given, or with metaripon 500 mg thrice a day, maximum up to 6 gram can be given. Definitive treatment of choice is complete excision of the tumor. Carcinoid lung tumors, they are uncommon group of pulmonary neoplasm of endodermal origin arising from stem cells of bronchial epithelium, also known as Kulczynski cells. They arise from the cartilaginous portion of tracheobronchial tree. They are vascular and pink to purplish in color. Clinical features include features of bronchial obstruction, that is persistent cough, hemoptysis, recurrent or obstructive pneumonitis, wheezing, chest pain, and pneumonia. They also produce biological active peptides and hormones which produce further symptoms. That is, if it is a serotonin producing tumor, then clinical symptoms include tachycardia, flushing, bronchoconstriction, diarrhea, and acidosis. If it is an ACTH secreting tumor, then it produces raised cortisol and ectopic Cushing syndrome, similar to our case. And if they are producing ADH, then there will be weight gain, secondary hyponatremia, weakness, confusion, and convulsions. And if it is a melanocyte secreting hormone, then it produces increased pigmentation. And investigations include serum chromogranin A, urinary 5-hydroxyindole acetic acid, ACTH, growth hormone, melanocyte stimulating hormone, elevated. They are elevated secondary to ectopic production. Imaging includes chest X-ray, CT, MRI, pituitary, gallium PET scan, and transbronchial or transthoracic fine needle biopsy for tissue biopsy. and treatment includes surgical resection, that is formal lobectomy or pneumonectomy, larger or more proximal lesion, segmentectomy or wedge resection, smaller lesions in peripheral location contained within single peripheral segment, thoracoscopic or open wedge resection for patient with limited pulmonary resource, and bronchoscopic resection only in selected cases. Recently, NDAG laser photosection of intrabronchial carcinoid are also being proposed.
Any comments from the audience, questions regarding the two cases?
Not that he knows. The patient, he was going around with this. But still he continued driving. He was going around with the weakness for at least 1.5 months. He never complained of respiratory weakness. ഒരു പ്രാവശ്യം in the morning while he was about to stand മാറ്റിയപ്പോൾ the bike and this guy fell. That is when the relatives took him to the hospital. He was never planning to come. He is still not surgically removed also. That.
Proximal muscle weakness, is it due to carcinoid syndrome or is it due to paraneoplastic?
Probably he had an ectopic Cushing's. The ectopic Cushing's, all the features might not be there. He actually had weight loss and no striae, no weight gain. I didn't know this. Then when I read up, so it can be a partial presentation. All the typical manifestations of Cushing's might not be there. So this could have been a proximal myopathy secondary to the Cushing's.
Anyway, an excellent case
Thank
with
you.
a typical presentation.
Thank you, sir. It was 6.4. HbA1c was 6.4. So, sir, initially the cortisol was high. It was already done. So then when we took over, he had a DVT. He was almost going into respiratory distress. So then we always thought it was a stress state. But later we were stuck with this acquired gentleman's, and then suddenly in the night, when we just struck, why couldn't it be? Because the CT, it was mentioned as a mass, but they put a impression as a breakdown infarct bar consolidation. But that is when it struck. Then when we read back about manifestations of ectopic ACTH, because I always thought that this ectopic ACTH will come like a typical Cushing's, but it's not, just partial manifestations, and he had weight loss. Everything goes against a typical Cushing's. So.
Another clue also could be the fact that there was a DVT which was to be evaluated for that age. There had to be an evaluation for a neoplastic syndrome. Many of times when patients are sick on a ventilator and they develop a DVT, we attribute that to immobility, obesity, so many times. But I think we have to give a chase for a occult malignancy, especially in atypical presentations. So that's another take-home message. And I think the obvious answer for both the cases combined is listen to your wife. She takes you to the hospital in time. My patient was also extremely erratic. In fact, I was going through his chart. He had been lost to follow-up for almost 3 to 4 years. And his diabetic control was terrible, 11 versus HbA1c. Then you start accommodating these patients because he was completely forgetful. In fact, incidentally, he came 3 days back to the OPD. And his wife was literally telling him what to do, So the clue in that history was the family history. His brother had the same symptoms. And as you age, beyond 50, the chances of developing this is 30%, the premutation. And more than 75, it's 75%. And the clue was picked up because he was very clear in saying that I am unable to register anything new. So he couldn't go to a shop, he couldn't get any transactions done, his bills were long pending. So, so a loss to follow up in a hospital is the last thing that he should be bothered about himself. So probably the wives, you should listen to your wives more often is what I feel from both the cases. Thank you for the opportunity. If there are any more questions, I think we can interact during the dinner. Sunny sir. No, sir. See, that was part of the clinical examination. In fact, if you see a lot of these FACSTAs, as you pronounce the syndrome, FACSTAs, there's a lot of atypical findings which are not explained. There's even a single line on a hand. Hastareka, there is one line. So many atypical presentations I mentioned. Hayat's palette is not classical of any of these things, but we just thought we shouldn't hide whatever was there as part of clinical examination as such. It was again, I wish the family just agreed for that FCR gene 1 study also, because it was not all that expensive, but the problem was they were on a insurance, so we had to actually document it, and the wife had a very pertinent question: is it going to alter your treatment? And the honest answer was no. And he said his elder brother is still alive doing the same thing, and for her the take home message was it doesn't affect his long-term survival. He's doing quite well. In fact, his sugars were at all this thing. I think the clue was a movement disorder. If we had to actually go only by the peripheral neuropathy signs or a mild dementia, this could all be explained by a slightly earlier onset of a mild cognitive impairment. But the ataxia, the tremor, and that forgetfulness with the family history, that clinched the deal. That MRI was almost conclusive. And as usual, we have Dr. Radhakrishnan Nair who just said, no, start working up on these lines. And then we got the history of this. There is even what we all usually read up is about the Fragile X syndrome. FACSTAS is one variant, and the female variant is a Fragile X primary ovarian insufficiency. So if you actually work up like that, everything is fitting in perfectly into that. So we just actually tried to push to get this into a publication mode, and they were still against it. In fact, when they came this time, I actually didn't want to ask them again, because we could have sponsored it for a PCR analysis without much of a strain. So probably the advantage of being in a government teaching institution is that I'm sure this would have been a teaching case or an academic case, and we could have pushed it and finished it off as a watertight case. One of the reasons why we don't publish as many cases as Westerners when it comes to literature publications. Thank you. The FACSTAs? I think we are missing it, sir, because the trinucleotide repeat is very common. It is not that rare. The only problem is probably in movement disorder clinics. I don't know. Maybe Sajish can help. The geriatric population, we really don't look into this in much detail. I don't know if the neurologists personally look into it a lot. But yes, when I read up the literature, it is not all that rare. It is not all that rare, but probably we are not tuned to look at it like that. We probably just, as Nitish mentioned, we just make it an atypical Parkinson or a movement disorder and just move on with that. And how many of these people will come back, sir? That's a question, because they don't have an insight to come back and show us. So yes, I think I myself would have missed a lot of these, because how many MRIs do we chase also? Because the diagnosis is very classical from clinical examination, family history, radiological evidence, and a gene plus or minus. So if you look at the diagnostic criteria that Nitish mentioned, you don't need a gene study to confirm this. It is just to conclusively put a stamp on it, but we don't need it. And the percentage of mutations actually is between 50 to 200 in most of these cases, the trinucleotide repeat. And females just don't present with neurological symptoms basically because of the absent X. So the X is actually overriding that. So that's the genetic study of that. I think we probably are missing it. We just don't look into it in that detail. And how many of us will write down a case history like this for a radiologist to report it like that? That's probably our own mistake. So I think, yes, that's what I feel. Anybody who's senior in the crowd can actually contribute regarding what the percentages and things like that. Shall we wind up? Thank you, API, for the chance again.